Uh, Hello, everybody, and great to meet you at this excellent session and all the great work that Know AML do. I'm a leukemia and transplant doctor in Birmingham, centre of the UK, and I've been working in this area for, I suppose, about 3 or 4 decades. It's longer than I care to remember. But I want to echo what Ralph has said about the remarkable advances in treatment of this disease, but still the major challenges in ensuring everybody has a good outcome, and also thinking about the very considerable effects that this diagnosis has on patients and their family caregivers. And also thinking, and as doctors, I'm sure we're not very good at this, about the toxicity and the complications of the treatments that we are delivering. We're in the UK very interested in trying to improve quality of life after transplant, and we've just commissioned a piece of patient and public involvement around supportive care in AML, and I think it's an area that's largely ignored. The messages that are coming through to us loudly when you sit and listen to patients and ask them what questions you want addressed, they're not about transplant, they're not about targeted therapies so much. It's more about the quotidian challenges and toxicities of the treatment that we deliver, effects on nutrition, on strength, on appetite, on nausea, permanent fatigue, coming into hospitals, treatment of infection, lengthy time in hospital for IV antibiotics. And I hope that these insights from patients will be framing our next grant, which will be focusing on, firstly, what can we do in terms of improving treatments of infections? Second is, what can we do to think about optimizing nutritional state of patients? Is the neutropenic diet of any benefit? What can we do to prevent muscle wasting and assist in patients' nutrition? And finally, what is the right threshold for red cell transfusion? But that's a sort of background to my perspective on where we are. I have a particular interest in stem cell transplantation. Ralph's right to talk about it as being a really exciting and curative therapy. And I'm just going to walk through a little bit around transplant. And then I want to also pick up this important point about making sure that we improve outcomes. So if I could go to the first slide, I think you control them, do you? These are my disclosures. So this is, sorry if it looks a bit like a sort of medical student talk, but these are the key points. We know that there have been significant advances in the drugs that we can use to treat a whole range of blood cancers, but particularly AML in the last 10 years, FLT3 inhibitors, venetoclax, and IDH1 inhibitors, CPX351. But still, for many patients, it doesn't eradicate the disease. And what's happened at the same time, really in the last, it's probably 60 years now, is there has been a steady progress in terms of understanding how to deliver transplants safely. I'm going to talk about that. And also how we make them a key part of the treatment pathway for patients who don't otherwise have curative therapies. And the reason is it's extraordinarily interesting, to my mind, certainly. The reason transplant's so effective is because it has a mechanism of cure that's distinct just from chemotherapy's ability to wipe out cells. And what it can do is, as you acquire a new blood system from your donor, from the transplanted cells, you also get a new immune system. That new immune system from the donor can recognize residual leukemia and kill it. So this is really the first example of immunotherapy. And it's most fascinating how powerful this effect is. So we know that partly because when we do a transplant, we can give stronger chemotherapy and then rescue people with a stem cell transplant, but also because of this graft versus leukemia, this new immune system. The most effective anti-leukemic therapy we have in AML is a transplant. So we need to be thoughtful about which patients are likely to benefit. Can everybody have a donor? And next slide, please. And also, how can we really be confident that we're delivering transplant both with maximum curative effect, but with minimum toxicity. So this is again some quite detailed data, but I think it's important that we kind of understand why people are so keen to extend the curative power of transplant. And I want you to look at this graph. This is from the Dutch group, the HOVON group. And what they did was there's a red line here, and the red line is comparing outcomes in patients with acute myeloid leukemia in first remission who had two choices. One is they could go to have just more chemotherapy and no transplant, or they could have a transplant. And what we're looking at here critically is this impact on the risk of the disease coming back. And what it shows here is if it's on the left of the red line, it means the transplant's better. And what you can see here is this really remarkable reduction in relapse risk in people who have a transplant. It's called, in posh statistics, a hazard ratio. The hazard ratio for relapse is 0.33, and that means a 67% reduction in the risk of relapse if you go to transplant. So jolly powerful way of dealing with the disease. Next slide, please. And the other way of looking at this is, well, how big is this graft versus leukemia effect? So let me just give you a bit of background about this graft versus leukemia effect. It was first observed in American studies led by Mary Horowitz and the Seattle group. Mary Horowitz was in charge of the US Transplant Initiative for many years, based in Milwaukee. And she made the observation that people who had a transplant and developed the main complication of transplant, which is graft versus host disease. That's when the new donor immune system sees the patient's skin or gut or liver as foreign and mounts an inflammatory reaction. And it can be extreme, it can be fatal. It's more often just a really nasty complication for patients. But she noted that if you had a transplant for leukemia and you developed graft versus host disease, you were much less likely to relapse. So that was an extraordinary publication. It was in the New England Journal of Medicine, because that was really profoundly saying that the only way they could explain those data was that something about developing graft versus host disease, in other words, something about the donor immune system giving you a rash or jaundice or diarrhea or being turned on, also reduced your risk of relapse. And then people went on to explore this further. And what they noted was three things. Was that when we do a transplant, we try and prevent graft versus host disease by giving patients a drug called cyclosporin. And we give it for about 3 months. But we routinely, when people are in hospital, measure their cyclosporin levels. And what we were able to show, this was some Italian group, and then our group in the UK in Birmingham, was we were able to measure the cyclosporin levels in a cohort of patients who'd had a transplant and correlate that with relapse risk and survival. And what we showed in that study was that if you individualized the cyclosporin exposure for each patient and then correlated that with relapse risk, that if you, this is the red curve here, if you had a lot of cyclosporin around post-transplant, in other words, there was a lot of drug accumulating in your blood to suppress that donor immune system, your risk of relapse was very much higher and your outcome was much worse. If you had a small amount of cyclosporin and your immune system wasn't suppressed so much, you did get more GVHD, but you got much less relapse. So again, that data can only be interpreted that there's something about the immune system post-transplant that is very powerful in terms of reducing relapse risk. And then the final is a sort of anecdotal story told to me by my old boss, John Goldman, about some very important work in Munich by Hans Kolb, where he had, in some animal models, demonstrated that in dogs with residual leukemia, if he gave them back, and this was after a transplant, if he gave them back lymphocytes from the original donor dog, the leukemia seemed to go away. So he was working in Munich, and he transplanted a young man who had chronic myeloid leukemia. This was when we didn't have imatinib. And in this young man, the disease came back. And so Hans sat the young man down and said, I'm really distressed to tell you that there's evidence of your leukemia coming back, and it's coming back quite early. And I'm not sure that there's much we can do. We've given you a transplant and the disease has come back. So this young medical student had read Professor Kolb's work in dogs. And he said, well, it's, I'm not the news I want to hear, Professor Kolb, but what I read about your work is that in dogs where the disease comes back, you can give them the lymphocytes from the original donor, and it seems to go away. Could you do that for me? And so Hans was horrified. He said, well, this has never been done in a human. If I did this, we might give you very severe graft versus host disease. So he said, I don't think I can do this ethically. So this young medical student said, well, you're telling me that the options really are very limited and that this is the only curative approach. So I really would like you to think very seriously about this. So Hans saw his point and agreed. This was before there were ethics committees and everything, and said, I'll ring round my colleagues. And so he rang a number of his international colleagues and said, in this setting, do you think it's reasonable? What's the risk of graft versus that? And actually all of his colleagues, including John, said, well, you've got to do it sometime, so I suggest you get going. And they had some joint thinking about the dose. So the patient came back, he got given the lymphocytes from the donor, they were harvested. And within 6 weeks, he was in remission, and he's alive to this day. So that's an extraordinary story, I think, in many ways. One is about bravery of the patient. Second is about medical ethics. That's a lengthy discussion. But thirdly is that's the most compelling evidence that when you up the immune system, the donor immune system, by infusing donor immune cells, T cells, you can get rid of leukemia. So next slide. So the reason we're interested in transplant is because you can exert this very powerful anti-leukemic effect that's bigger than you can get with drugs. And that's why we think about transplant in patients with acute myeloid leukemia now. Next slide. So the way that the transplant works is that we take a patient who has leukemia, and once we found a donor, and we started off using brothers and sisters who matched, we would give the patient chemotherapy and typically radioimmunotherapy to kill the leukemia, suppress their immune system, and then give them bone marrow initially, but it's now peripheral blood stem cells from the matched donor. Next slide. And this is how we used to do transplants up to 25 years ago. It was limited to fit adults under 50, high-dose chemotherapy, high-dose radiation. You certainly couldn't do it in somebody of my age. Next slide. And what you wanted to limit was the graft being rejected by the patient. Well, either TBI or nowadays fludarabine does that very well. And you wanted to exploit this graft versus leukemia effect while limiting the graft versus host disease. Next slide, please. So that's how a transplant's done. But let's think about, before we think about how we extend this so that it's useful for all patients with leukemia, let's just think about the toxicities. So when we do a transplant, and this is true to some extent, even today, these are data from about 10 years ago. The major complications, life-threatening complications, are toxicity to the organs, so that's kidney or heart or lung. I say to my patients, their 100-day risk of that's about 3 or 4% over a year period, but at 100 days, it's about 1 or 2%. There's a risk of lung toxicity. There's a risk of infection, and there's a risk of graft versus host disease. So when we think about the challenges for patients going through transplant, it's very much to do with making sure we limit the toxicity to their lung or their heart or their kidneys, thinking about preventing infection and using drugs like cyclosporin. And now we have a drug called cyclophosphamide you give post-transplant to prevent the risk of GVHD. But that aside, I want to draw your attention to the fact that the disease coming back is still a major challenge. You can go through all this and the disease in many people goes, stays away, and they're cured. But in a significant number of people, about 30%, it can come back. Next slide. So the purpose of this slide is to show that actually transplants got safer. So the complications and the likelihood of life-threatening complications in the first year has really dramatically reduced. In this period, this was a New England Journal paper, in the first decade of this century compared with the last decade of the last century. You can see it's halved, and that progress has continued. So the risks we would estimate to a patient having a transplant at 2 years is about 15%. They've got a well-matched donor. Still 15% too much, but it's much better than it used to be, and that's better infection control and better ways of preventing graft versus host disease. So, you know, it's really encouraging that it's safer now. Next slide. And so part of this in counseling patients about whether to go to transplant is how safe would it be for me, doc? And these are data that were put together by the Seattle group, looking at people having a transplant, and then validated at MD Anderson. Next slide. And this is a score that we now widely use. If anybody is considering a transplant, you are scoring them on the basis of what we call comorbidities, the illnesses they had before they came into hospital. I still think the most important indicator, and I do this regularly on a Monday morning, is how fit the patient was before they got acute myeloid leukemia. You know, patients who are walking 3 or 4 miles or cycling, and even if they've got some of these things, they're pretty well. So you score people in terms of diabetes, inflammatory bowel. You can see the risk list as well as I can. The really important ones that concern us would be renal impairment, the lungs having been affected by excessive smoking or previous infections, and heart disease and liver disease. So when people have those, perhaps particularly together, they're probably, next slide, not fit enough to go to transplant. Because what we can see is when you build that score, that if you've got a score of more than 3, there are exceptions where you can do a safe transplant, but the risk of the transplant compared with people who are totally fit is totally different. Next slide. And we did this work in the UK, and it just shows that in older people over 60, I'm going to come to older people in a minute, that we as a population are much less tolerant of comorbidities. So once your number of comorbidities is more than 1, in your 60s or 70s, you really struggle with a transplant. Next slide. And that's because of, you can see what we call non-relapse death, but that's treatment toxicity, transplant toxicity. Next slide. So as I said, up until about 25 years ago, on the left, you're seeing young people under 40 with acute myeloid leukemia in remission, have a transplant because they've got a donor, or they don't have a transplant, they haven't got a donor. But you do better if you get a transplant. The problem was then, historically, in older people, certainly above 50, the toxicity of high-dose chemotherapy and radiation was so much that we couldn't transplant patients. So older patients, even if they're fit, despite the fact they had leukemia and they needed maximum anti-leukemic therapy, it wasn't safe to proceed to transplant. So, next slide. The world changed when it was demonstrated by 3 groups. One, a group in Israel. The second is a group in MD Anderson. And then the third was a group in Seattle. Argued with great elegance that if the graft versus leukemia effect is so powerful, maybe we don't need this intensive chemotherapy which you give in a conventional transplant. And maybe we just give some degree of chemotherapy and an immunosuppressive drug like fludarabine, which means the graft isn't rejected. The new graft you get new donor stem cells, but a new donor immune system to kill the leukemia. And that hypothesis was, really edgy when it was put out there. But it's been proved to be absolutely visionary. Next slide, please. Because now, with a reduced intensity transplant, we get rid of this very toxic drugs and radiation that you give before the stem cells are infused in that week before you infuse the stem cells. And you actually just have a well-tolerated immunosuppressive regimen called reduced intensity, aiming to get full donor chimerism. The donor immune system is fully from the donor. Next slide. And bingo. It works. Stem cells will engraft. People were skeptical. They had no need to be. And the transplant-related toxicity is significantly reduced. It's still there, but it's significantly reduced. And that allows us to give a graft versus leukemia effect in fit patients up to 70, and actually increasingly, certainly in the United States, but in many European centers, up to 75 in a fit patient. And we've now got long-term follow-up. These are highly curative strategies. And they have a slightly higher risk of relapse than the full myeloablative transplant a young person will have. But they're so much safer. There's a real benefit in older people. Next slide. I'm kind of moving towards the end now. And these are data showing survival benefit of a reduced intensity transplant. Next slide. The challenge, of course, is the disease still can come back. So this is really bitter for patients, is you go through all the workup for a transplant, you have the chemo, even though it's reduced intensity, it's still tough. Then you have the stem cells, and you go through the risk of GVHD, and you're in remission, you're fine. And then sometime between day 90 and a year or year and a half post-transplant, the disease comes back. And often there's very little we can do. There are better strategies for getting people back into second remission, and young people, maybe a second transplant. But most people in whom the disease comes back, really, it's a very challenging setting. So I just want to kind of put out there for you, we're working hard on this as a community to think about how can we, in that initial treatment that we give patients to get them into remission, when you present, use maybe in people of my age, rather more gentle induction treatments rather than intensive chemo, that we have a higher complete remission rate. We're thinking about how can we make those drugs that we give before the stem cells are infused more effective. And then we're thinking about how can we use drugs after the transplant to maximize the anti-leukemic effect. Next slide. And then finally, I just wanted to draw attention, kind of, well, echoing what Ralph was saying, this is a really exciting time for treatment of leukemia. There's still so much challenge in terms of the toxicities and in terms of many people having recurrent disease, that it's completely misleading to say, this is a golden age. But at last we can see treatments coming through that are in particular settings effective, and more people can have a curative transplant. The challenge is, as I've told you, is there's still toxicity from transplant, and the disease can still come back. And so in the UK, we've been particularly interested in making sure that we do in patients who have a transplant, the randomized trials that in the treatment of myeloma or leukemia or bladder cancer would be deemed pivotal to improving patient outcome. And the fact is, it's important, because still, although many patients have excellent outcomes after transplant. In particular settings, still more than 50% of patients won't survive a transplant free of leukemia. And yet, certainly in the UK, and I think this is true in Europe, but I think it's the same in the US, fewer than 5% of patients having a transplant actually go on to prospective transplant studies asking these questions. Next slide. So we felt that this was really important to address, and so I and colleagues have raised £3.5 million to set up a network across our country, one of the biggest health economies in the world, where we put research nurses into big leukemia treatment centers, transplant centers, allowing us to work together to deliver prospective clinical trials asking these questions. Next slide. And when I tell you that we thought this was a good idea as clinicians and patients, you'd be surprised how skeptical the government was, senior health administrators. Oh, you can never recruit to transplant trials. Transplanters don't work together. Patients don't want to go on studies. And we got tired of this, really. So we just, after 7 years of making the argument and writing, but we just got on with it, got money from the charities. And our ambition was to randomize in a 4-year pilot, 400 patients. And we were amazed how much the transplant community wanted to work together, how keen patients were to access new treatments so their outcomes might be better, but also this enormous untapped altruism that patients have, that, doc, even if this doesn't help me, at least it's going to help somebody else. And they also, I think, felt they were in a wrapper of care where they had an extra research nurse and they were on a prospective study. So we entered this with some trepidation, because when people tell you at a high level something's going to fail, half of you believes them, despite the fact the rest of you thinks they're not right. So bingo, next slide, please. We were delighted that over this 4-year period, we randomized 1,300 patients. It's absolutely unprecedented, because before this, we weren't really delivering transplant studies in the UK. Next slide. And it's not just the UK, it's a problem in Europe, and I know it's a problem in the US as well. So we're now delivering a whole series of trials that are trying to ask about how do we improve transplant outcomes.